Hi, this is Brian Kim. I'm going to share with you case number 60 in the best way to do cataract surgery series. This is an average lens density with a medium pupil. You'll see lens disassembly techniques using double chop, cross chop, how I'm able to systematically disassemble this lens, even though the pupil is a little bit small. This lens is, again, not terribly dense, but again, just showing a standard technique for cataract surgery. So this patient is really have a very strong Bell's reflex. This is the left eye. She's also moving around quite a bit. So I'm using the cotton tip to stabilize the eye and just telling her where I want her to look. I'm using the cotton tip to stabilize the eye, and then we're making our paracentesis incisions, first on the right and then the left side. I want to make sure the incision is flat to the iris plane, which will create a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine and then intracameral epinephrine to see if it can stabilize the pupil, and then some dispersive viscoelastic. We use a cannula to hold the eye steady. This patient, again, have a strong Bell's reflex. I'm using the cannula to hold the eye steady, turning the eye downward, make a vertical groove for my triplanar corneal incision, place the blade into the deep part of the groove, tunnel through the cornea, use a cannula to turn the eye towards me, and then I enter. So again, you can see this patient's got this Bell's reflex. She's just not really that cooperative. We're doing the best we can. So I go in with the forceps, and this is a puncture style Rexis technique. I punctured, but it didn't go straight towards me, so I'm grabbing the flap on the left side, and then I'm going around in a counterclockwise manner. I'm going to use the corneal marks to help me in achieving a well-centered and sized Rexis. So that is the benefit of a smaller size pupil. You can use the pupil for your Rexis. So I burp the viscoelastic, and this is a Capsulorhexis hydrodissection technique. I place the cannula underneath the Rexis edge contra-incisionally, point the tip down, get a nice fluid wave, decompress on the left side, and then point the tip down on the right side and try to spin the lens here. This lens is really not spinning that great. And so, as I've said before, in lenses where I get good hydrodissection, but it doesn't spin very well, I am a little bit concerned that this patient may have some weak zonules, or at least some zonule laxity. So irrigate the surface of the eye, make sure my tip is correct, lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, and then placing the chopper underneath the ridge all the way to the equator, pointing the tip down, turn the phaco tip vertically subincisionally and fracturing the lens in half. That's a double chop. Place the chopper around the right heminucleus to the equator, pulling it centrally towards the phaco tip, fracturing the right heminucleus. That's the cross chop. I lift the first quadrant up with some vacuum, and then I'm sandwiching and crushing the lens piece with the chopper and phaco tip, and then emulsify the lens pieces. Perform the same maneuver under the second quadrant, placing the chopper under the equator, pulling it centrally against the phaco tip. I'm able to divide that quadrant into smaller pieces, lifting a fragment up with high vacuum, and then crushing the lens piece between the chopper and the phaco tip. So I'm going to use a chopper to tease that second quadrant away from the rest of the lens, and then getting around it with a chopper, and then lifting it up with high vacuum and removing the lens piece. Again, using mechanical fracturing forces to crush the lens pieces into smaller pieces and then emulsify. So I'm turning that second heminucleus in front of me. You can see I'm just very carefully and gingerly turning the lens piece. Is just kind of acting a little stuck. It's not really turning very easily. Place the chopper around the lens piece, pulling it centered towards the phaco tip, fracturing it nicely. This is, again, one of those brittle lenses. They're kind of chalky, a little bit annoying, also sticky. But again, I do suspect the zonules are probably not great here. So I pulled that third quadrant up and started using mechanical fracturing forces to crush the lens piece. Using some vacuum to lift that fourth quadrant up, and then using the chopper to tease and separate off the epinuclear shell from the endonucleus, and then using mechanical fraction forces to crush the lens pieces into smaller pieces and emulsify the lens pieces. Once the endonucleus is removed, I'm going to start to remove the epinucleus, trying to find an edge where I can grab the epinucleus, and I found it right there. But again, you can see the epinucleus is still stuck and adherent to the capsular bag, which is, again, pretty typical in this sticky situation where the lens doesn't want to come up. And so you saw I wrapped the chopper around the edge of the epinucleus and prolapsed it up. So that's really a neat maneuver, being able to pull that epinucleus up with the chopper. I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece, start to remove the cortical material. You can see it was wanted to just kind of come all out in one piece, but you can see all these little wisps. And so that's another characteristic I've noticed with these lenses, that it doesn't really come off very cleanly. There's a lot of cortical material that's still left behind. So I'm very carefully sweeping underneath the rhexis edge, trying to make sure I use very minimal vacuum and aspiration so I don't grab the capsular bag or the zonules. And so I'm in the polish mode doing this. Just gives me a lot more confidence that even though I'm going underneath the rhexis edge and I can't visualize it, I'm not going to actually cause too much traction in the process. But I can see that there's quite a bit of cortical material, so I'm just happy to take my time since I am in the polish mode, rather than going too aggressive and then grabbing the capsular bag and zonules. I'm just going to have to go very slowly, removing these fine little pieces of cortical material still stuck. And then I start polishing the posterior capsule as well. I can see that there's some fine wispy material in the subincisional capsular bag. And even though it's not obvious that there's material that's stuck on the posterior capsule subincisionally, there is. And so I'm using that polymer tip that in the polish mode to really confidently remove or at least loosen up that lens material. You can see there's still large sheets of cortical material on the left side here as well. So once I'm satisfied that I cleaned the bag up as much as possible, I use a cannula and pulse the subincisional capsular bag, and you can see that there's a bunch of crap that starts coming out subincisionally, as well as a little bit to the right side as well. I'm going to inject some cohesive viscoelastic within the bag to inflate the bag, and then I'm going to switch to the sweeper. I'm going to try to polish in the subincisional area first to see if I can loosen up some of that cortical material. If I can, great. If not, I can get it after I put the implant in. So I'm polishing with the sweep on the left side first, and then the right side. I'm injecting the single piece acrylic intraocular lens into the capsular bag. The leading edge goes into the bag, the trailing edge is out of the bag. So I'm going to go in with the INA, activate the fluid once I'm in, separate the leading haptic and then trailing haptic off the optic, go underneath the lens, tilting it sideways, rotating the lens 90 degrees clockwise, removing all the viscoelastic from within the bag, making sure that the posterior capsule is clean as well, repositing the lens in the bag, and then start to remove the viscoelastic from the anterior chamber. Remove all the viscoelastic coated on the corneal endothelium as well here. So I'm pushing BSS into the angle, making sure there's no viscoelastic trap there, and then I'll hydrate my incision. So again, this is a medium pupil, moderately dense lens, really kind of a predominantly sticky consistency and nature to the lens. The lens didn't want to spin, even though I had good hydrodissection. Again, this could be due to the lens, but also due to the zonules. Perhaps there's some zonular laxity. But the point is, I can still systematically disassemble this lens with double chop, cross chop, mechanical fracturing techniques using the chopper and hooking lens pieces up out of the bag. I feel confident doing it this way, and I really don't have any trouble taking out sticky, dense lenses that don't want to spin in the bag. So I hope this was helpful to you, and I thank you for your attention.